Hello, this is Dr. Lowell Chambers. In this discussion, we're going to endeavor to provide a precise and kind of shortened overview of time-controlled adaptive ventilation methodology of airway pressure release ventilation. Now, this is a very truncated discussion. Please see more thorough discussions regarding both the why of TCAV at the first podcast listed there and the how of TCAV. Both why I think that TCAV is the optimal methodology, at least for ventilation, at least in the trauma and surgical critical care setting, and how you utilize TCAV effectively following the tenets established by Dr. Nader Habashi and the group of Baltimore Shock Trauma. These are giants whose shoulders I'm just attempting to stand upon. This is not my work, just trying to utilize the work that's been done by others for the betterment of our patients. But this podcast is meant to be a very abbreviated version for those that may not have the full attention span for both podcasts. But for more information, please see both of these podcasts, as I do think there's more important information than I have time to go over to in this 1 hour podcast. But in looking at TCAV, or time-controlled adaptive ventilation, as effectively employed by the team here and others at Baltimore Shock Trauma, I believe there is good argument in the literature generated by these and now some others, which suggests that TCAV APRV is a superior vent mode for most, if not all, of our trauma and surgical critical care patients. They've also got a website, which I would refer to you, tcav.net, that the Shock Trauma Group has put together, which is very helpful. I would like to think that my podcasts are helpful, but certainly going to the authorities on the matter is probably an even better thing to do, and tcav.net affords you that opportunity. Well, as we start our discussion, let's start by briefly looking at the primary publication, which established what most hold as the current standard of care in regards to ventilator management of ARDS patients, the May 2000 New England Journal ARDSNet trial. This was a randomized prospective trial, multi-center in nature, conducted between 1996 and 1999 with 861 ARDS patients by the then AECC criteria. The control group was ventilated with a assist control volume control with a tidal volume of 12 milliliters per kilogram, whereas the study group was similar otherwise, but ventilated with a tidal volume of 6 milliliters per kilogram. And they also had plateau pressure criteria as well. As most everybody is aware, the study was stopped early after interim analysis demonstrated statistically significant improvements in survival and time to extubation with the lower tidal volume strategy. This established the ARDSNet low tidal volume ventilation, ACVC, as standard of care for ARDS management, and also had a significant influence on the ventilation of most of our other respiratory failure patients as well, with kind of the mindset, which I think is an appropriate one, that if it's good for treatment of ARDS, it's also potentially helpful in prevention. Unfortunately, this has not been associated with the anticipated improvements that we would have hoped for, as the mortality of ARDS, I should say, has remained static in the 35 to 45% range. And as one investigator put it in the Current Opinions of Critical Care in 2014, the incidence and overall mortality of ARDS has not changed substantially since the original ARDSNet study. The current mortality of adult ARDS is still greater than 40%. So this lack of improvement in outcomes with ARDSNet low tidal volume ventilation raises some questions regarding the initial trial. And a group of investigators at the NIH actually did this back in 2005, and although their findings seem to have been pretty much overlooked and or perhaps suppressed by the ARDSNet consortium, I believe there's an important message in their article here: mechanical ventilation in ARDS, one size does not fit all. I think it's an important message regarding the standard of care status of ARDSNet low tidal volume ventilator management. They actually utilized the Freedom of Information Act and gained access to the primary ARDSNet data, and it turns out that the 861 patients enrolled in the trial represented only a quarter of those eligible. The remaining three-quarter patients, or almost 2,600 patients that were not included in the study, were not included for a number of reasons, as kind of listed here. The most important message, though, I think from this slide is not the reasons they weren't included in the study, but the fact that their outcome data was followed, and these patients were ventilated with a mean tidal volume of 10 milliliters per kilogram, again, as compared to the study group of 6 milliliters per kilogram. And look at the outcome difference here, essentially none. So the 2,600 patients not included in the study, but which met criteria for inclusion, ventilated at a significantly higher tidal volume, no difference in outcomes. This is an important message, I think, for us. Additionally, and perhaps even more significant, the patients which were ventilated with a low tidal volume ventilation in subset analysis and under closer scrutiny of the study group, those patients with very stiff lungs did indeed benefit from the low tidal volume ventilation. But in patients that had a bit more compliant lungs, not as severely reduced compliant lungs, actually had worse outcomes with lower tidal volume ventilation protocol, leading the NIH investigators on this review to conclude that in light of the marked relationship between compliance and mortality in the low tidal volume arm of the trial, a single ventilatory strategy such as 6 milliliters per kilogram tidal volume ventilation may not be ideal for all patients with ARDS, or the term was invoked in acute lung injury. In other words, one size really does not fit all. And it's likely that we need more adaptability, if you will, in regards to ventilation of ARDS patients. One size does not fit all. Or as Dr. Franklin put it years ago, if everyone's thinking alike, then no one is thinking. Well, two investigators who have been willing to think and apply independent thought to ventilator issues are Dr. John Downs, who developed airway pressure release ventilation a number of years ago, and Dr. Nader Habashi, a pulmonologist at Baltimore Shock Trauma, who over the last several decades has refined what he refers to as time-controlled adaptive ventilation, or TCAV, a methodology of airway pressure release ventilation. And the primary characteristics of TCAV are a long inspiratory time, or a T-high, which comprises typically greater than 80 and usually 90% of the cycle, with intermittent, very low pressure, but very short releases, and those short releases being adjusted based upon expiratory flow curves. So an adaptability, if you will, a built-in custom ability to how compliant the patient's lungs are. It utilizes time rather than pressure parameters to favorably influence pulmonary mechanics. And utilizing what evolved into TCAV, different iterations of APRV, but ultimately a refinement to the principles of TCAV as they now have published. Dr. Habashi and the shock trauma group have seen significant improvements in ARDS mortality, with initial reports out of their institution with this approach decreasing their ARDS mortality to around 21%, certainly favorable compared to the ARDSNet study, but again, not directly comparable groups, but nonetheless, an optimistic sign. And then as TCAV became more the standard of care at shock trauma, more recent publications demonstrating a decrease in ARDS mortality into the single digits, and perhaps even more impressively, a decrease in the occurrence or development of ARDS. Now, it's important to clarify that not all airway pressure release ventilation is time-controlled adaptive ventilation. TCAV is a specific methodology of APRV, and other uses of APRV may not have and likely do not have the same benefits of TCAV. And so there's a lot of studies out there with APRV that have mixed outcomes, but are not utilizing the TCAV methodology, and it's important to distinguish TCAV from these and not discount the benefits of TCAV based on APRV studies using different methodology. Well, what are the characteristics of TCAV which facilitates such favorable outcomes? I believe there are 6 main benefits, if you will, or 6 main characteristics which contribute or which are noteworthy in regards to the benefits of TCAV. And again, we go into greater detail in this on the first podcast, but one main reason is that it facilitates high-level support of hypoxia with significant reversals of I/E ratio with maintenance of spontaneous breathing. And this is of great benefit as spontaneous breaths, as opposed to positive pressure ventilator breaths alone, favor ventilation of the larger, better vascularized lower lobes and permits more homogeneous lung ventilation as compared to positive pressure ventilation, which disproportionately favors the smaller, more poorly vascularized upper airways. This translates to less atelectasis and hypoxia, as demonstrated by this ARDS model study with the spontaneously breathing lungs at the bottom here, showing much better aeration than the purely mechanically ventilated model at the top here. Additionally, as the mode is particularly comfortable, or relatively comfortable, it essentially feels the same as CPAP. This allows for patients to receive much less sedation with the associated benefits of decreased delirium, decreased cubital formation, decreased hypotension, etc. All of those benefits that come from having to use less sedation. And also, there's no need really for a spontaneous breathing trial, as the patients are continuously breathing spontaneously. And in regard to neuromuscular relaxation or neuromuscular blocking, it essentially, with the patient spontaneously breathing, accomplishes the majority of the benefits that occur from neuromuscular relaxation and pronation, preventing these from being necessary. And so neuromuscular blocking, pronation, you can simply accomplish the same mechanisms that those create benefit with utilization of TCAV, but without the downsides of having to prone the patient, which are huge, obviously, from just a logistic standpoint, and sometimes from a mechanical complication standpoint, but also not having to paralyze patients is obviously of huge benefit. And a number of investigators have seen with utilization of TCAV methodology, this includes in the medical setting as well, essentially a significant decline, and in some instances, preventing from having to put any patients on neuromuscular blockers or any patients from being prone, or at least significantly decreasing it. So these 3 kind of occur kind of together, they kind of go together, but why TCAV APRV? It allows for spontaneous breathing along with concurrent reversal of I to E, so providing significant support for profoundly hypoxic patients, but with less sedation and neuromuscular blocking need and without the discomfort that comes with I to E reversal otherwise. Perhaps the most important advantage, though, of TCAV is the mitigating effect it has on ventilator-induced lung injury. Now, in order to understand this, it's important to clear up a misconception. Ventilator-induced lung injury does not appear to occur due to high airway pressures alone. It's not an over-distension thing. Let me say that again. Villi does not occur, I believe the preponderance of the evidence supports, due to high airway pressures alone. The critical factor which leads to lung injury from ventilation is the shear stress placed on alveoli with repetitive opening and closing. It's like taking a thin piece of metal and you bend it once, maybe with a great deal of force, as compared to bending it back and forth multiple times, which is what will lead to breakage. Gary Neiman and Nader Habashi have eloquently demonstrated this with a ventilated porcine model in which two groups of pigs were both ventilated with high plateau pressures of 40 centimeters of water. The groups differed, though, in regards to how frequently the alveoli were allowed to collapse. And in the patients in which the alveoli were allowed to collapse frequently via standard ACVC type of ventilation, as compared to those instances in which the alveoli were essentially nudged open with a TCAV methodology and kept open, there was significant differences noted between these two, despite the airway pressures being the same. The dynamic parameters, the cytokine indices, and most impressively, perhaps, the anatomic and histologic appearance of the lungs on autopsy demonstrated minimal injury with the low dynamic strain TCAV group, whereas pig lungs subjected to the high dynamic strain with repetitive and frequent alveolar opening and closing, as associated with ACVC type of ventilation, showed evidence of significant injury, as you can see here on these pictures taken after necropsy. So it's the movement, it's the multiple episodes of alveolar collapse and re-expansion which cause the injury, not the pressure level. And here's just another example of this from Mr. So up here is assist control, volume control ventilation. Down here is TCAV. You see all the movement going on up here. You see basically stability down here. So much less shear stresses going on here. Let's look back at that again just for a minute. Standard low tidal volume type ventilation up here. A lot of movement, a lot of shear stresses, alveoli opening and closing frequently. Down here, relatively static situation. Here's another example, this time with a rat lung model, again from Mr. Neiman's work.
So what we have here is a rat lung with that has ARDS. The ARDS class part is pink, or is dark red, and the pink is the healthy tissue. We're going to hold this at inspiration for 1 second, and which is a typical conventional breath inspiratory peak. And as you can see, there's no change in the red to the pink. Here we're going to have the TCAV breath. We're going to hold it for approximately 5 seconds, which is a typical CPAP phase or T high. And you'll see at the exact same inspiratory pressure how many alveoli we're going to get recruiting. So here, as you can see, we're at 3, 4, 5, and you can continually see the red going to pink over these 5 seconds. So the exact same pressure in the CMV and the TCAV breath. The only difference is the inspiratory time is held a lot longer. So this is, and again, due to this viscoelasticity, this is what is causing the lung to progressively open or to be nudged open over time.
Again, you know, I think a striking difference, picture's worth 1,000 words, so to speak. Here you see the minimal addressment of the atelecto trauma, if you will, from ARDS here, as compared to significant overcoming of it here, as was demonstrated well in that model by Mr. Neiman. So why TCAV APRV? It allows for spontaneous breathing along with significant support of hypoxia with relatively low amounts of sedation and decreased need for neuromuscular blocking. It is associated with decreased ventilator-induced lung injury. It's also associated, for the most part, with improved hemodynamics. And there are multiple studies in the surgical critical care, medical critical care literature, the neurocritical care literature, cardiology literature, even some cases in the OB literature where APRV, particularly with TCAV methodology, is associated with better left heart function and better hemodynamics. Now, exceptions are with right heart failure, with pulmonary hypertension. Those patients do not do very well with TCAV. So if you've got significant right heart failure, that may be one setting. If you've got significant pulmonary hypertension, that may be a setting where TCAV isn't a good vent mode. If patients have unaddressed hypovolemia, if a patient is inadequately volume resuscitated, they will tend to get hypotensive, particularly with higher P highs. And so you'll tend to drop your blood pressure even with TCAV APRV if the patient's not adequately volume resuscitated. So you have to be sure to be adequately volume resuscitating your patient as you're initiating TCAV methodology. Otherwise, you will get hypotension. Outside of that, there's multiple experiences in the literature speaking in pretty much uniformity that hemodynamic profiles, blood pressure, urine output, left heart function are improved with APRV as compared to other vent methodology. Now, we don't have as much time as I would like to review the literature, and I again refer you to my 2 podcasts for a more extensive review. But I would like to take a couple minutes here to focus on the main article, which kind of made me a TCAV believer, if you will. This is a retrospective review of a previously obtained prospective database from Baltimore shock trauma with elevated risk trauma patients who were at elevated risk for ARDS. And the rationale for their study, as outlined here, was that they hypothesized that early application of airway pressure release ventilation before ARDS development in high-risk trauma patients could reduce ARDS mortality and perhaps even reduce the incidence of ARDS. So they had 231 polytrauma patients, all of which had at least one femur fracture, so increased risk of fat embolism syndrome and therefore ARDS. Higher ISS scores for inclusion criteria had to have an ISS score of 17 or above, and these patients were treated as shock trauma between 2002 and 2005. And they compared these to essentially all available US literature with significant numbers of ARDS patients in the trauma setting where outcomes could be tracked between 1995 and 2012. So a little bit over 66,000 patients across 16 studies between 95 and 2012, which afforded outcome data on ARDS in the trauma setting, and then comparing that with the ARDS occurrence and outcomes to this high-risk subset of patients from shock trauma between 2002 and 2005. And the results were fairly striking, with a mean ISS score of 29.7 in the shock trauma group as compared to 25.7 in the meta-analysis group. So the shock trauma patients were somewhat more severely injured based on ISS criteria. The mortality outcomes were nonetheless better at shock trauma, with a mortality rate of 3.6% as compared to 14.1% in the meta-analysis group, of which no patients died from respiratory failure. No patients died from ARDS. And regarding the incidence of ARDS, 14% overall in the meta-analysis group, essentially zero, 1.3%. I think only 2 patients in the shock trauma group developed or met the criteria for ARDS. So significant improvements or a significantly better overall mortality, a significantly better or lower incidence of ARDS with the shock trauma TCAV approach. And these were ill patients. Looking in more detail at the shock trauma subset, again, mean ISS of 29, mean lactate level on admission of 4, almost 80% had chest AIS scores of 3 and above, a number of other organ systems which were injured, Just as a reminder for those not familiar with the AIS scoring, what does it mean when they say they've got a chest AIS of 3 or above? It means they've got something really bad, either multiple rib fractures or a lower number of rib fractures with hemothorax or pneumothorax, or more severe things such as aortic laceration. So these are severely injured patients. Again, all of them had at least one femoral shaft fracture. Some had more than one, and that certainly increases the ARDS rate due to the increase in fat embolism rate. Large volume resuscitation in these patients, looking at the entire group, mean volume within the first 24 hours of 11 liters. For those that were transfused, we're talking an average of 7 units of PAC cells, 8 units of FFP. And so these are patients getting significant volume resuscitation, which in and of itself increases the risk for ARDS, and was a marker for patients you would expect to have a worse outcome. And then specifically looking at the ARDS occurrence, applying the previously multi-center validated lung injury prediction score, the LIP score, the lung injury prediction score. The demographics of the shock trauma cohort are associated or were associated with an anticipated ARDS rate by LIPS criteria of 38%. So LIPS criteria, again, developed multi-institutionally, other study outside of this one, but applying the LIPS criteria to this series, 38% of these patients were predicted to have ARDS, the observed 1.3%. So a profound reduction in the observed as compared to the predicted ARDS rate with the shock trauma approach, leading to the conclusion that early application of TCAV APRV in high-risk trauma patients can significantly reduce ARDS mortality, but perhaps more importantly, incidence. These findings warrant further research because it's a potential breakthrough from treatment of an established syndrome, one with relatively poor outcomes, to prevention before ARDS developments. And this is what has really resonated with me, because it's always better to prevent a disease process than to try to treat it after it's developed. And so why TCAV APRV? Because it allows for spontaneous breathing, because it's associated with less sedation and neuromuscular blocking need, because it allows for significant IDE manipulation without the need for discomfort and significant sedation, because it is associated with decreased ventilator-induced lung injury, because it's associated with improved hemodynamics. And we didn't take time to review the literature, but again, it's on the podcast, because with the spontaneous breathing maintenance, it helps maintain diaphragm muscle tone. And based on the shock trauma and now other centers' outcomes, improved outcomes with ARDS and decreased incidence of ARDS. So which of our patients that are being ventilated should be on TCAV APRV? I would argue the answer, and this is the way they put it as shock trauma, the answer is the same as who should wear a seatbelt when they're driving in a car. Everybody. Now, the majority of the time you're driving in a car, you'd be just fine without your seatbelt, but you never know when the need's going to arise. Every patient that goes on the ventilator is at some risk of ARDS developing because of the potential for pneumonias, because of the potential for ventilator-induced lung injury, and the other things that go along with mechanical ventilation. So put them all on TCAV. Just as seatbelts save lives, help mitigate injuries after motor vehicle crashes, TCAV, based on the shock trauma data, I believe, convincingly decreases the potential for ARDS developing in patients that have to be put on the ventilator. Very briefly, a few quick case studies. The first is from shock trauma, and I got this from a very nice presentation that senior respiratory therapist there from shock trauma, Maria Madden, did several years ago. This is a patient who came in severe ARDS, was actually being prepared for ECMO there at the University of Maryland, and the respiratory therapist is Miss Madden relates it, kind of pleaded for one shot at TCAV APRV. The surgery team told her they'd give it an hour, and if the patient didn't show improvement, they were going to cannulate. So here's where the patient came in at 4:30 in the morning on 100% FiO2. despite that becoming hypoxic, high peak inspiratory pressures on, pretty much maxed out here on PRVC, low tidal volume ventilation, significantly acidotic, and improved pretty profoundly and quickly with APRV. So they stuck with APRV, and by 3 hours later, with having the patient on a P high of 36, P low of 0, T high of 2 seconds, T low of 0.65 seconds, you can see the pH is in much better range at 7.36. PCO2 has gone from 61 to 29. PaO2 has improved to 216 on the same amount of oxygen support. And the P-to-F ratio has increased from 72 up to 223. And the patient was able to avoid going on ECMO, was ultimately extubated 11 days later, and went home. Here's a case from my own practice within the last several weeks. This is an extremely morbidly obese patient who came in, 93 BMI, who had a necrotizing soft tissue infection of his abdominal wall due to an incarcerated umbilical hernia containing a perforated colon. Patient was in significant septic shock, requiring vasopressors, requiring significant volume resuscitation. He's got severe sleep apnea, which has been untreated, and again, profoundly elevated BMI, required damage control colectomy, significant abdominal wall debridement. We managed this in kind of a staged fashion here, so multiple returns to the OR, significant fluid support for the septic shock and significant fluid shifts. Very difficult mobility in this patient, hard to do anything when, at 680 pounds, most of the hospitals, chairs and other support apparatuses wouldn't support his weight. We couldn't get CT scans. We couldn't get fluoro studies because he was too high. Again, the severe obstructive sleep apnea being a significant issue. We put him on TCAV from day one. This is the worst chest x-ray I could find from the entire admission. This is as bad as his chest x-ray ever looked. So this is a patient that, has significant morbid obesity, significant sleep apnea, significant volume resuscitation, profound sepsis, but we were able to oxygenate him well with minimal settings, minimal need for Precedex and narcotics. The patient was actually able to, once he was out from the initial sepsis, participate in much of his care. He was able to self-suction. He assisted with his own care, his own movement, which was of enormous benefit in this patient who's obviously very hard to mobilize. You can see very nice flow dynamics here, utilizing TCAV from day one. Now, we did ultimately trach him just because he had to return to the OR so much, and everybody was appropriately so scared when he would, lay flat and stuff. He just wouldn't do well. But we were able to pretty quickly decannulate him, and in retrospect, probably would have been able to get by without having done the trach. And he never required significant oxygen support. No evidence of pneumonia, no complications. Again, this was the worst the chest x-ray ever looked. So TCAV APRV, I think it works. And the reasons why I think we should be using it, again, go over them more broadly in the longer podcast, but hopefully this has at least given you a little bit of the rationale for why I think switching to TCAV APRV, at least with our trauma and surgical critical care patients, makes the most sense. Having done that, how does it work? And I think that's most people's reluctance is, they haven't done this before. And so it looks from the outside, looking in, it looks complicated. And things which are different and complicated tend to, be a little bit difficult for us to embrace. I promise you that although it may seem like rocket science at first, it's not. It really isn't. It's fundamentally, essentially just CPAP with releases. It is, however, different. We're used to typically setting and adjusting a rate, a tidal volume, PEEP, sometimes an I to E ratio. Well, with TCAV, you don't set any of those things. You set an FiO2, you set an oxygen setting. Outside of that, everything else is different. That doesn't, however, mean that it's hard. Again, all TCAV is airway, is an application of APRV, airway pressure, so essentially CPAP, release ventilation. It's just like CPAP with these intermittent releases thrown in. So as you're setting the vent and as you're adjusting the vent, you've got two pressures and you've got two times that you apply those pressures. You've got a P high, which is essentially the same as the P that you set every time you put a patient on CPAP. And then you've got a T high, though, which is the time you keep them at that PEEP. And then you've got a P low, which is the pressure that you drop the patient to for these very brief releases. Now, we never actually get to that pressure because we keep the time of that pressure release so short, and we're going to talk more about that. But in setting and in adjusting APRV, you've got a P high and a P low, and then you've got the times that you keep the patient at each of these pressures. That's it. It's not rocket science. Well, let's look at each of these settings a little bit more. P high is the peak pressure that is reached and the one that's held for the majority of the cycle. If you're transitioning the patient from conventional ventilation, if it's AC, VC, you're going to typically set it at what your previous plateau pressure is. Or if it's AC, PC, so patient on pressure control ventilation, you're going to typically go with the peak inspiratory pressure. I'll be honest with you, I usually bump the pressures a little bit higher, and I'm going to talk about why I favor a little bit higher P high in patients, but that gets you in the ballpark. It's typically when you're transitioning a patient or starting a patient, going to be between 20 and 45, and again, high pressures, right? But don't let that, get your underwear in a wad. It's not the same as when you're applying these high pressures with the typical ventilation because it's not occurring. These high pressures aren't being associated with repetitive alveolar shear forces. The alveoli are being nudged open, as Mr. Neiman likes to say, and kept open. They're not being subjected to these villi-inducing shear pressures. And sometimes I've gone as high as 50 here even. Now, where you'll pay a price is in regards to hypotension. We're going to see that higher P high levels will help with both oxygenation and with CO2 offloading. And so they will help address both hypoxia and hypercapnia. You can address that by increasing P high. Both of those are helped by increasing P high. Where you got to watch is if you go too high with a P high, the patient will become hypotensive, particularly if they're not adequately volume resuscitated. So again, very important that these patients are all adequately volume resuscitated going into the TCAV. But then even inadequately resuscitated patients, if you're working with very high P highs, you may start to deal with some hypotension and you may have to come down based upon that or due to that. How long do you hold the P high for? And I think one of the biggest mistakes that people make right away is they start trying to stretch out the T high too early. If you have a patient that's in a rescue type situation where they're in extremis and you're transitioning to TCAV APRV, you typically are going to have to go pretty low with the T highs initially because those patients need bulk ventilation to offset the hypercapnia, which is being experienced typically along with the hypoxia. And if you put them at more typical T highs that you'll utilize during the weaning phase, they will not do well. They'll become more hypercapnic, more acidotic, and they will not do well. And then people will say, oh, APRV doesn't work. No, it didn't work because you're not using it appropriately. The T highs we're going to see, one size doesn't fit all, and we're going to talk more about that. But you'll typically start low unless it's a patient who's very stable. You start anywhere between 2 to 5 seconds. I favor starting around 2 and then building up from there. P low on the Draeger vents at shock trauma, they always set them to 0. I typically on the GE vents we use set it to 1 just because I don't exactly understand what it is, but something weird happens with the GE vents. It's kind of like with tube compensation. Tube compensation is probably a good thing to use on the Draeger vents and other vents with APRV but the algorithms or something with the GE vents are just, things just go haywire. So I do not use tube compensation, and I don't drop the P low to 0. I just set it to 1. It's a negligible difference. We're essentially following the spirit of shock trauma, which is you set the P low to 0 so that you avoid as much as possible all airway resistance during that offloading time, so that you get the most bang for your buck with your very brief release, so that the most CO2 possible can be offset. Whereas if you leave the P low higher, you're going to have more resistance. That's going to hamper your CO2 offloading. Now, you never really reach the P low because the T low is so short. Your T lows are typically set anywhere in the 0.2 to 0.8 second range. Sometimes you'll be longer than that, but typically the releases are very short. You're just giving a very brief pop off to such that you really never reach the set P low. Again, you set it very low so that there's less resistance, but the time that you're allotted, it takes about 1.5 seconds to release all of that pressure, and we're not giving it that long typically. So you're usually releasing only about a third of the pressure. So let's say your P high is 30, you're probably only making it down to an actual pressure, or an auto peak pressure, if you will, of about 20. If you're at 30, you're only making about a third of the way down typically, because the T low is so short. So P high, somewhere in the range of the previous plateau pressure, and typically going to be between 20 and 45. T high, I usually start around 2 seconds and then build up from there. And as the lungs get better, you can stretch that out. And we're going to talk about that in regards to weaning here shortly. P low, I always set it to 1 on the GEs. At shock trauma on their draggers, they set it to 0. T low, this is a little more complicated. This is the time the patient is given to release. It's usually, again, very short, typically between 0.2 and 0.8 seconds. This is the adaptability of TCAV, time-controlled adaptive ventilation. The adaptivity comes in regards to how the T low is set. You typically want it to be between 50 to 75%. You want the expiratory function to truncate at 50 to 75% of peak expiratory flow rate. So once you've dropped your flow rate by 50 to 75%, then the release phase needs to end and you go back to the P high again. If you leave it longer than that, then you lose your auto PEEP and you really lose the benefit and the nudged open lungs, if you will, that TCAV APRV is affording you. And we're going to talk more about setting the T low here in just a moment. But prior to that, important to recognize that while we emphasize the releases for CO2 release, because that's why that's built into, APRV. That's why you don't just do high PEEP CPAP. That would be great for oxygenation, but you typically don't have in these ill patients enough ability to spontaneously breathe off CO2, and your alveoli are too collapsed to permit adequate alveolar ventilation and offloading of CO2. So you add these releases in. But as the patient becomes better and is able to breathe stronger, more spontaneously, and as their alveoli open up more, this first and third mechanism of CO2 clearance become more effective, leading to less dependence upon the releases, therefore allowing you to stretch your T highs out because you can get by with less T lows now, less intervals at the low pressure because you don't need the releases as much. And so you gradually increase the length of the T high, decrease the number of periods of going to P low, or decrease the T low number of occurrences. And before you know it, you're at CPAP. And then the patient's ready to extubate, hopefully soon thereafter. But again, one size does not fit all. You cannot start with a one-size-fits-all approach to setting, particularly the T high with TCAV. Just like this English bulldog is finding out the dog door that works for the dachshund doesn't work for him, one size does not fit all. And so you have to recognize the context within which you're ventilating the patient. If you've got a patient with severe ARDS, you can't put them on the same type setting that you'll be able to get away with in a patient that has normal lungs. If you try putting a patient in severe ARDS who's already respiratorily acidotic on a T high of 4 or 5, you're going to likely get worsened acidosis. Those are patients that need a T high that are down in the 1 to 2 second range, so that you're getting a lot more releases at that point, more offloading of CO2, and the patient's hypercapnia is addressed appropriately. Whereas, a patient that you're just kind of putting them on TCAV prophylactically, you will, or it's a patient that just is coming out from surgery or something and they need to stay intubated for a little while for whatever reason, yeah, then you can go probably with a higher T high if they've got normal lungs. But you have to understand the severity of illness of the patient. And if in doubt, start with the more severe settings. I typically start, all other things being equal, if it's not a full-on rescue situation, I'll start out somewhere around the P high at 28 typically. P low I always set at 1. T high I'll typically just start with 2 and go from there. T low, it just depends on what the flow parameters look like. I'll start somewhere usually between 0.4 and 0.6, and then I just kind of see what their tidal volumes do and what their flow patterns look like. And we'll talk about that in just a moment. You have to recognize, though, that a respiratory cycle with TCAV is T high plus T low, right? That essentially equals a breath. And so you can essentially take a patient if they're on ACVC or ACPC and look at what their current respiratory rate is, see how their gas is doing, and then kind of figure out where you need to be as you extrapolate, recognizing that a respiratory cycle is T high plus T low. That would equal essentially the equivalent of 1 breath. So how do you figure out what to set your T high at? You're going to set your T low based upon flow dynamics. We're going to talk about that, or flow parameters. We'll talk about that in a second. And then to figure out what your T high is, your T high is just essentially that number minus 60 divided by respiratory rate minus T low. Or a better way of looking at it is recognizing that, okay, you got 60 seconds in a minute, right? And so you want to divide, take 60, divide your respiratory rate by that minus the T low. That'll give you your T high, essentially. Here's an example. Here's what your previous respiratory rate was 30. 60 divided by 30 minus 0.4 is your T high. 2 is what that comes out to, obviously. You've already figured in this example, your T low needs to be 0.4. That means your T high needs to be 1.6. You can't take this patient and give them a T high, for example, of 4, or you're going to become significantly hypercapnic. Now, in regards to ventilation and oxygenation, it's like the Lego movie. Everything is awesome by increasing P high. You can improve your oxygenation. You can improve the CO2 offloading by increasing P high. So from a ventilation standpoint, from an oxygenation standpoint, everything's awesome by increasing P high. Obviously, you're going to pay the piper, though, in regards to hemodynamics. If you do go too high with the P high, the patient's going to become hypotensive. So you have to watch the patient's pressure carefully, particularly as you're dealing with higher P highs. But when you're particularly in a rescue mode, you may need and will probably need to start very high with the P high, and then you need to leave them there. Okay, the alveoli will open up fairly promptly, but they will not stay open. If you try weaning too soon, you try to drop that P high within a shorter time frame than 24, 36 hours, depending upon how ill the patient is, you will be right back in the same boat you were in before. The opened alveoli are not stable for at least 24 and oftentimes 36 hours. Dr. Abbasi likes to use, Maria Madden likes to use the example of, the corollary of taking an orthopedic surgeon who's seen a patient with a fracture and they put a splint or a cast on that fracture. You can't take that cast off the next day just because you got a good reduction initially, right? It has to have time to heal there. It's the same way with the lungs. The time course is a little bit different, but once you get the lungs propped open, you have to hold them there for a while or they're just going to recollapse. So unless you're having hypotension that's compelling you to have to decrease the P high, don't wean the P high for at least a day in rescue cases. Also, avoid interruptions. You're depending upon auto P, so things which break the circuit are bad. And this is hard for us because these are things that with other vent modes are often helpful. With TCAV, they're harmful. Breaking the cycle, breaking the auto P for suctioning, bagging the patient, transports on different vent modes, inhalers. These are things which interrupt the auto P. They interrupt the nudging of the lung open and will lead to recurrent alveolar collapse, and you'll lose what you've gained. So don't wean too soon. Don't interrupt with neb or inhalational meds or transports on other vent modes. Don't bag the patient. Don't suction the patient. If you're salvaging them with TCAV, you've got to keep that auto PEEP in place. And don't wean until the patient's ready, both time-wise, and you should be able to get them down to an FiO2 of 40% before you start dropping the P high. Again, unless you're compelled by hypotension, keep that P high up. Now, that's for very severely non-compliant lungs or severely ill lungs. With patients that you've got on TCAV that maybe their lungs are a bit more compliant, have to be careful. If you go too high on the P high, these patients can become hyperinflated. Here's a patient before TCAV. Here's a patient shortly after TCAV. The lungs have cleared out too quickly. The diaphragms have become flattened. The mediastinum has become narrowed. This is a radiographic picture of hyperinflation, and this will typically be associated with hypotension. The patients will become uncomfortable and look like they're trying to force exhalations. Their waveforms will become squared off. And this is a patient that you're causing problems with. And so there you need to decrease the P high promptly, perhaps increase the T low concurrently. And now you may pay a consequence in regards to oxygenation, and you'll just have to make it up elsewhere, maybe by increasing the T high, most commonly increasing the FiO2 if you've got room to do that. But most of the time, that's not an issue because most of the time, these patients, their lungs aren't amongst, the severely ill ones you're taking care of because those lungs aren't able to become hyperinflated because they're too stiff normally. So typically, if you're seeing hyperinflation, that's what it will look like. Recognize it early and drop your P high. Now, the other thing that can give you that picture is tension pneumothorax, obviously. So get the chest x-ray, make sure they don't have a tension pneumo. The data that we have would suggest that pneumothorax rate is no higher with TCAV than it is with other vent modes, but with all positive pressure ventilation modes, you do have some increased risk of pneumothorax. So think about tension pneumothorax and the potential need for chest tube, but it may also be hyperventilation, and that's what it looks like, and the treatment typically is to decrease the P high, which most of the time, if it's occurring, the patients will tolerate. So again, if you're struggling kind of with becoming comfortable with TCAV, you don't necessarily have to remember, all of this, all of these specifics and the concepts and things. I think you ultimately need to know them to do this right, but just make a screenshot of this and make a screenshot of the one I'm going to show with the adjustment in a minute. And, fall back on this when it's the middle of the night, you don't really have time to do a lot of thinking and stuff, and you just need to do something quickly. Just, utilize this as a guideline for how to get a patient on TCAV APRV appropriately. Okay, as we move toward closure here, setting the release phase, the T low. This controls the amount of airway pressure and lung volume released. It facilitates a transfer of potential to kinetic energy generated by recoil within the thoracoabdominal cavity. It's the adaptive, really, component of time-controlled adaptive ventilation. And the way that you do that is adjusting the T low to an expiratory flow truncation occurring at 75% of expiratory flow peak. That's where you want to be. How do you do that? Well, you do it by understanding flow curves, which is something I've not utilized enough in the past. I'm trying to learn now and kind of catch up. My pulmonary colleagues are certainly much better at this than I, but I've learned a lot from them and from the shock trauma groups and others with online education and things. But here's what, as a general surgeon, simplistically, we'll just put out there. Here's what a flow pattern looks like if you allow the patient to completely exhale. There's going to be this period of time where you initially start exhalation, where you're at peak expiratory gas flow. So you're releasing and the gas is coming out quicker. As the gas of the lungs is emptied, this gradually slows down and eventually reaches nothing because there's no more gas to exhale. So it's kind of this triangular appearance, if you will, to the expiratory flow rate here. Now, if you truncate the expiration, if you stop it at about 50%, so if you stop it at about 50% of the peak expiratory flow rate, it looks more rectangular, looks more square like this, less triangular and more square if you're terminating at 50% of peak expiratory flow. Whereas if you terminate at around 70-75%, as is recommended for TCAV methodology when you're treating restrictive lung pathology such as ARDS, it looks more rectangular like this. And so you just kind of learn to recognize what these flow patterns look like, and you kind of can target and tweak the T-low until you get this appropriate appearance. Where do we come with that 75%? Don't have time to go into it. I do go into it on the longer podcast, but the shock trauma group has looked at this, and the optimal outcomes are facilitated by setting a T-low at a 75% termination of peak termination at peak 75% of peak expiratory flow rate. Just looking at Denver, and here's what it basically looks like on the GE vent. Now, you can measure this and you can get kind of quantitative about it, and early on in your experience, that's probably a good idea. It's important, though, to recognize some things about the expiratory flow patterns here. This is an expiratory flow spike. This is actually an artifact. This is an artifact of gas recoil. This is not the expiratory flow peak. The expiratory flow peak is actually right here at the kind of the right-sided upper aspect of that, the site of the initial widening. That's truly the expiratory flow peak. This is just a gas recoil artifact. And that's important because if you're measuring out what your peak expiratory flow rate is, and you can do that on the G vents, it's a little bit clunky, but you basically hit here to capture, and then you hit here to show what you've captured. It'll reflexively bring up the most recent one. You can go back and look at old ones, but it'll initially bring up the most recent flow pattern. And then you go over to where that peak expiratory flow rate is, which again is going to be right here, not here, but here. See what that is, and then you just come over to see where you're truncated at. That's pictured here. And then you see what the ratio is. Here it was about 60%, if I recall correctly. And then if you're at greater than that, then you need to shorten the T-low some. If on the other hand you're like at 90% or something like that, you're not giving them enough, then you increase the T-low some. And this may change from day to day, that as the lungs become hopefully more compliant, your T-low need may change because your parameters of the expiratory flow will change. When you've got very stiff lungs, the peak expiratory flow rate tends to be very high because the lungs are under such pressure. When you give them a chance to release, it's coming out very quickly. Whereas if you have somebody on the other hand that has pretty significant COPD or other obstructive lung pathology, it's much slower. And so the T-lows, will vary depending upon the amount of restrictive and obstructive lung pathology that you have available or lack thereof for each of them. And so this is the adaptive phase. Now, this is a little bit clunky to do, but honestly, what I do in reality, and I do measure this frequently, but what you can also do is just sit there and just kind of watch the patient after you switch them over. And I think it can't be emphasized enough that as you put a patient really on any vent setting, but particularly on TCAV APRV, it's important that you hang around and just watch and see what the patient does for the first 5 minutes or so. See what type tidal volumes they're getting. See what their spontaneous respiratory rate is or becomes if you've got a paralytic on to intubate them or to ease the transition as that comes off. If they become increasingly tachypnic, if they're getting very low tidal volumes, if they look uncomfortable, if they're more tachycardic, then something's not going right. You need to tweak something. If they're getting very low tidal volumes down in the hundreds or 200s, then you probably need a little bit more of a T low, for example. If they're becoming hypotensive, then maybe your P high is too high and you need to adjust that. So these are all things that I just kind of sit there and I kind of tweak a little bit. I come up with an initial setting here in this ballpark and keeping these things in mind and a set of parameters. But then once I've got an initial setting, see how the patient responds to it. Maybe they're an undiagnosed COPDer. And so maybe they need a longer T low than you would have anticipated. Maybe they got more stiff lungs than you anticipated. Maybe their lungs aren't as stiff as you anticipated, and you're getting tidal volumes of like 900 over here, and they're at risk for hyperinflation. And so just sit there and kind of tweak it along with respiratory therapy and nursing and communicating your thoughts. I think it's important to work as a team on these patients, certainly. And then once you've, the patient's kind of been on it for, 5-10 minutes or so, and you're at a good place, set up a plan maybe to get a gas in an hour or so, and you go from there. But don't just intubate, give a vent setting, and walk away. That tends not to work well. And again, you can do the formal measurements here, but I think just as helpful oftentimes just standing at the bedside and seeing how they do. Okay, we need to finish up here. I want to keep this around the hour time frame. So, where it's initially an uncomfortable thing, setting TCAV, because we're not, familiar with setting a T high and a T low and a P high and a P low instead of a respiratory rate and a tidal volume and all of that. In similar fashion, it's a little bit uncomfortable at first how you adjust it. Well, again, one thing to remember is whether it's hypercapnia or hypoxia, as long as you're not hypotensive, you can improve things by increasing the P high, especially early on. Other ways to improve oxygenation: increase the T high or decrease the T low, or both. So by decreasing the amount of releases or the time of release, you favor oxygenation, but you'll pay a cost on CO2 blow off. So if the patient's concurrently hypercapnic, probably best just to focus on increasing the P high. Obviously, you can increase the FiO2 if that's appropriate. If they're having problems with hypercapnia, again, you can increase P high, but you can also, if they're doing okay from an oxygenation standpoint, you can decrease the T high, you can increase the T low, or you can do both. So you're giving them either more releases or a greater or a more prolonged release. Obviously, you don't want to get the releases to get super long, or then you'll lose that auto PEEP, especially if you get over 50% of your peak expiratory flow rate that you're truncating at. So this is how you adjust the vent. So again, as you're uncomfortable maybe in switching over to TCAV, but you want to do it, make a screenshot of this screen, make a screenshot of this screen, and that's really what you can fall back on, hopefully. Weaning. Weaning is different with APRV. It's a drop and stretch, as the shock trauma group refers to it. As the patient's alveoli become more open, as they become more functional, you're going to get more alveolar ventilation and therefore more CO2 offloading from that. You can become less dependent upon the releases, so you don't need as many of the releases. So by going with longer T highs, you'll get less T lows, and that's okay at that point. It's not okay early on, particularly if a patient's in extremis. And you can drop the P high down as you stretch the lungs out. Typically, we'll drop a P high by 2 at a time, and concurrently increase the T high by 0.5 at a time. And you just kind of work this way, and as you get down in this range, you're starting to get towards CPAP, and the patient may be ready to go on formal CPAP and do away with the releases and just allow them to offload their CO2 through their spontaneous ventilation that they're doing on top of the CPAP and through the alveolar ventilation, and you don't need the releases anymore, and then they're likely ready to extubate soon thereafter. Now, this is not where you start a patient, and this is a mistake I made. Dr. Abashi published this years ago, so I was like, oh, here's the algorithmic approach to TCAV. I'll just put all the patients initially on T high of 4, P high of 35, we'll be good to go. No, this is for weaning, and this is just an example. These numbers may differ somewhat, but the point is that as you wean the patients, you're dropping the P high, typically in increments of 2, you're stretching out. And with severely ill patients, it may be a long time before you're able to wean them. There's some SARS-CoV-2 case reports out there, of patients needing to stay with a high PI for weeks, for weeks at a time. And so don't think you're necessarily going to be ready for this, within just a few days. You're definitely not ready for it within a few hours. Again, get the patient on a PI, and as long as they're not hypotensive, stay there for 24 to 36 hours before you even think about dropping and stretching. Again, here are the longer, more complete podcast. Thank you for your attention and for your dedication to trying to improve the ventilatory management of our critical care patients.